The broadcast
There
is
you go.
now starting. All attendees are in listen-only mode.
Good evening, Leon van Rensburg, RSSA Congress Director. Welcome to the first in a series of 10 monthly head and neck imaging webinars. And it is my real honor and privilege to welcome and introduce my friend, Dr. Richard Wiggins III. Dr. Wiggins is a Professor of Radiology and Imaging Sciences at the University of Utah Health Sciences Center in Salt Lake City, Utah, USA, and Adjunct Professor in the Departments of Otolaryngology, Head and Neck Surgery, and Biomechanical Informatics. He received his BA in Biochemistry from the University of Texas, Austin, and his MD degree from the University of Texas at Houston, HSC. After a surgical internship and a research fellowship in head and neck imaging at the University of Florida, he completed his residency in diagnostic radiology at the University of Mississippi and his neuroradiology fellowship at the University of Utah. Dr. Wiggins has more than 50 peer-reviewed scientific papers, 11 books, 100 book chapters, and presented 500 national and international lectures on neuroradiology, informatics, and teaching and education. He is currently the program chair of the Society of Imaging Informatics and Medicine, the SIIM. He is past president of the Western Neurological Society and the American Society of Head and Neck Radiology, ASHNR. And at this point, I can just mention if any of you have not attended one of those meetings, you should make an effort to do so. He was elected as the inaugural fellow of the Academy of Medical Science Educators for the University of Utah Health Sciences Center and is the recipient of the Distinguished Teaching Award from the Department of Otolaryngology at the University of Utah, as well as the Honored Educator Award from the Radiological Society of North America, RSSA as we know it, as well as other teaching awards. He was also named the 25th Fellow of the Society of Imaging Informatics and Medicine. Dr. Wiggins is CAQ certified, and that means there's an additional neuroradiological qualification by the American Board of Radiology and also certified by the American Board of Imaging Informatics. Now, I think it's obvious to all of us that we are really privileged to have such a distinguished radiologist, teacher, to give up more than 12 hours of his time over a period of 10 months to advance our digital teaching platform, advance head and neck radiology. And all I can say is thank you very much, Rick, and also thank you very much for allowing us to record this lecture and put it on our website for our members. Welcome, and over to you.
Okay, thank you. But now I feel a lot of pressure. Thank you, Dr. Rensburg. So as Dr. von Rensburg mentioned, we've tried to put together a lecture series for you about head and neck imaging over this next year. So we'll be having a bunch of lectures we'll talk about global head and neck imaging today, and we'll talk about some complex areas like temporal bone anatomy and pathology and the central skull base, as well as some cranial nerves, and we'll finish up with lymph nodes. So we'll try to do one of these lectures every month for the year in 2019, and you can find the schedule there from Dr. von Rensburg. So we'll start off with each of these spaces, and I'm going to go through in all these lectures, all these complicated areas in the head and neck world: the skull base, the temporal bone, cranial nerves, sinonasal, orbit, some oral cavity, and we'll talk today some about the suprahyoid and infrahyoid neck and the complicated anatomy that's around these areas. And for each of these lectures, we'll try to define all the important anatomy of that area, and then we'll look at the imaging pathology and see how complicated pathology affects that anatomy in each of these regions as we go through the head and neck for this lecture series. Now, majority of what I'll be talking about is CT and MRI. So this is a CT scanner if you haven't seen one open before. So we have something making radiation and something detecting radiation, and it's turning around very quickly. And we remember all the time that this machine is just a big, stupid densometer. We're looking at densities of stuff. But you see why we have the machine closed. If you've never seen it open before, this is what a CT scanner looks like when it's revolving very quickly. And we ask the patient to voluntarily put part of their body right in the middle of the bore there. So I've got a CT scanner, and the CT scanner is very helpful for looking at densities of stuff. For example, there's an area, the jugular foramen, we'll talk about later, but I know that when I see permeative destructive changes, like we see here in this picture, that's a very good appearance for a periganglioma. And if I see increased density, I know that's very good for a meningioma. And if I see smooth scallop margins, I know that that's very good for a schwannoma. So looking at densities of tissues, especially around the skull base, I can sometimes tell you exactly what the pathology is. That's a very exciting thing for us as imagers, to tell the differences in bone between these different series and be able to tell you exactly what the pathology is based on the density. So I have the CT scanner looking at densities, and I have an MRI scanner looking at our protons, and we're mostly water, and looking at how those protons move in the magnetic field. So a majority of what I'll be talking about in this lecture series is CT and MRI. So for the MRI scanner, if you haven't seen it before, we had a scanner that we were trying to sell or dismember, but we weren't able to. So we spent a weekend kind of doing experiments and different materials going inside the scanner. Here you see a pair of scissors going back and forth through the MRI scanner. And remember that magnetic field goes back and forth. This is a MRI pole, and you see those red tape around the IV pole telling me that it's not safe to go in the MRI scanner. You can see this pole being pulled into the scanner. So it's a very strong magnetic field, much stronger than the Earth's magnetic field. And these scanners are always on. They're on all the time. And this is an oxygen tank. One of the most dangerous things here, you see here's a watermelon, a cantaloupe, and a coconut. And these were some concrete blocks that we got showing the oxygen tank actually crushing these concrete blocks. Here it's in the wall about 15 feet behind it. So we remember that MRI scanner is on all the time. And why is that important? Well, this is how the general public sees MRI scanners. Here's a video from a James Bond movie, and James Bond turns on the MRI scanner, and the gun is pulled up along the scanner, and then James Bond turns off the MRI scanner and grabs the gun. And that's what people generally think about MRI scanners, but in reality, they're on all the time. And here's why this is important. This is a referring physician who thinks he's helping by bringing the bed in the room at our MRI scanner here at the University of Utah a few years ago. And he's actually bringing the bed in the room, and it gets pulled out of his hands, and it's slammed up against our MRI tech. Here's the view inside the room, and we can see our MRI tech here getting the patient out. We don't need to bring the bed in. The bed comes out of the scanner. And here's the bed being slammed up against the MRI scanner. And now two people are trying to pull the bed away from the MRI tech as he's trying to get out. And he had lost sensation in his leg and had large black and blue marks down his leg for several weeks afterwards. So these scanners are very dangerous, and we're getting better and better at imaging body parts while they move. So that's an important thing for us to be thinking about all the time. So in addition to CT and MRI, we also have nuclear medicine studies, and this is where PET-CT is very helpful for us in the head and neck world. So we have a CT scanner, so we're looking at densities of tissues. So we know that air is very dense, air is not dense, so that's black. Bone is very dense, so that's white, and everything else is in between. But it shows the importance of windowing when we start looking at these studies. It's very important when I start looking at a soft tissue neck study that I window level somewhere around 440 so that fat is different than air. Because I know that where there's air and where there's fat is very important for a lot of the pathologies of the extracranial head and neck. But in addition to CT, I also have nuclear medicine where I can see areas of increased uptake. And PET-CT is very helpful to combine those two. So I see the anatomy with CT, and I see the biophysical properties with PET, and I combine those in PET-CT, for example, to see here this retropharyngeal node. So that's a majority of the modalities I'll be talking about in this lecture series. We'll be talking mostly about CT, MRI, and PET-CT, mostly in the cancer discussion, and how we use PET, how we use PET-CT as well as MRI and CT in the extracranial head and neck for a lot of these complex pathologies. So today we'll be talking in global sense. So here we have the upper digestive tract. We have nasopharynx, oropharynx, and hypopharynx. And here we've filleted open the upper digestive tract. And we'll be looking first at all the spaces around that anatomy while we think about the suprahyoid neck and the infrahyoid neck. So we're going to start off today talking about global head and neck anatomy of the cervical soft tissues. In the suprahyoid neck, we think about all these fascia layers. So we see here outlined in these fascia layers in yellow and in blue and in purple, all these different fascia layers that define the suprahyoid neck into all of these different spaces. This is very important for us while we think about the different spaces of the suprahyoid and infrahyoid neck. I don't personally think it's so important to remember the names of all these layers in terms of the middle layer of the deep cervical fascia or the deep layer of the deep cervical fascia or the buccopharyngeal fascia or the prevertebral. But I do want to remember that these fascial layers exist and they define these anatomic spaces in both the suprahyoid and infrahyoid neck as we go through them. And a lot of these spaces are tubes, so they extend up in both the suprahyoid neck and the infrahyoid neck. There's a lot of variability to these fascia layers, but they're relatively good barriers to infection and cancer and different pathology. So sometimes pathology is directed superiorly and inferiorly within these well-defined spaces in both the suprahyoid and the infrahyoid neck. So we're going to start off today looking at the suprahyoid neck in those spaces. And I'm trying to talk as best I can about these areas before the surgeons get here, before they get to the operating room. And I know that 25 years ago, when I looked at cervical soft tissue neck masses, I would say it could be any one of 20 or 30 different pathologies. And if I think about these fascia layers, I can be much more specific. So I want to think all the time about these fascia layers that define these suprahyoid neck spaces. I want to think about what anatomy normally lives in those spaces, and then I can make a space-specific differential. So first we're going to talk about the suprahyoid neck, and then we'll talk about the infrahyoid neck today. So in the suprahyoid neck, we think about all of these lateral spaces: parapharyngeal, pharyngeal mucosal, the masticator space, the parotid, and the carotid spaces, and we'll go through each of these spaces. So I'm going to take this same axial T1 image, and I'm going to outline for us all of these spaces in the suprahyoid neck. So I'm going to take this same image and outline all of these spaces. So first, we'll talk about the parapharyngeal space, or fat. So we have this triangle of fat that's within the lateral suprahyoid neck. And this is important because how this fat is displaced sometimes helps us guess the space origin of pathology. Now, it's mostly fat at this location. There are a few small vessels. Some people have published there are lymph nodes normally in the space, but I like to think about this space as really just being fat. Sometimes a couple little vessels, but really it's just fat at this location. And we have a very small connection superiorly of that parapharyngeal fat, and it goes down and is contiguous with the submandibular space that goes under the mandible itself. So we really think about just fat being at this location. It has a connection inferiorly with the submandibular space and a very small connection way up high at the skull base. Now, there's no critical contents in this space itself. We see here its connection at the central skull base itself, and we see how these other spaces are around that parapharyngeal fat. So this fat becomes very important when we think about the suprahyoid neck, because how that fat is displaced helps us guess the space origin of pathology in the suprahyoid neck. So now we're going to go around the lateral superhyoid neck spaces and define each of these spaces and talk about how they interact with that parapharyngeal fat. So we'll start off first with the pharyngeal mucosal surface or space we see here in blue. So this is around the upper digestive tract. So we have the mucosa of the upper digestive tract here. We have some lymphoid tissue and a little bit of minor salivary gland tissue that's within this space. And this is really where squamous cell carcinomas live. That's what we're usually talking about at this location. So here's that same axial T1 pre-contrasted image. And again, I find that parapharyngeal fat. And here I've outlined for you the pharyngeal mucosal surface or space. So I see where that is in relationship to that parapharyngeal fat out laterally. So if I have a generic lesion of the pharyngeal mucosal surface or space, I see how it's going to push that parapharyngeal fat back posteriorly and laterally. So when I see that fat push posteriorly and laterally, I can guess that the lesion is arising from that pharyngeal mucosal surface or space. So that's the anatomy. Now we'll look at pathology that happens at the pharyngeal mucosal space. So we start off with just lymphoid hyperplasia. So we see here prominence of the lymphoid tissue within the nasopharynx. And I was told 40 years ago or so and 30 years ago in training that if we had prominence of the nasopharyngeal soft tissues and the patient was over 50 or so, that patient either had nasopharyngeal carcinoma or lymphoma or minor salivary gland carcinoma, and they needed to be scoped. But I sent a lot of patients to be scoped 25 years ago or so, and I know now that if I see these linear septations within that adenoidal tissue, it's most likely just prominent lymphoid hyperplasia. It's probably not an underlying mass. And as I've paid more attention to the different sequences we use, I know now that I can use the T2 as well as the ADC sequence as a rough marker of tumor cellularity. So I pay more attention to these normal sequences. So anytime I see soft tissue present that's prominent along the upper digestive tract, I look for these linear septations to tell me that it may just be prominent lymphoid tissue. Now, I'm often trying to differentiate that from a tonsillar abscess. And we talk sometimes about a PTA or peritonsillar abscess probably being the most common upper air digestive tract infection. So anytime I see a fluid collection with surrounding enhancement, I'm going to think about an abscess in the upper air digestive tract surfaces and in the suprahyoid neck. So in this case, I see a fluid collection with surrounding enhancement on this post-contrasted CT, and if it's focused within the adenoidal tissue that we think about with the palatine tonsil, I'm going to think about a peritonsillar abscess. But we actually have a spectrum of pathology we might see at this location. So here's an axial post-contrasted CT. I see the carotid and the jug. The vessels are bright. And here I see prominence of the palatine tonsils on both sides. But again, I see those linear septations within that adenoidal tissue. So that tells me that this may just be prominent adenoidal tissue. This may just be tonsillitis at that location. I want to differentiate that from an intratonsillar abscess and a peritonsillar abscess. So here's an axial post-contrasted CT. Now I see a fluid collection on both sides with surrounding enhancement. Now, in the cross-sectional imaging world, we might call this an intratonsillar abscess if the fluid collection is confined to the palatine tonsil. If that fluid leaks out into the surrounding tissues, then on cross-sectional imaging, we're more likely to call that a peritonsillar abscess if the fluid leaks into the surrounding areas. So we have a distinction here that we make on cross-sectional imaging, even though the head and neck surgeons and the pathologists may say that these are all PTAs, peritonsillar abscess. We know that on imaging, if we see those linear septations, that's more likely to be just tonsillitis, prominent lymphoid tissue hyperplasia. If we see a fluid collection with surrounding enhancement on cross-sectional imaging, we call that an intratonsillar abscess. And if we see fluid with surrounding enhancement and that fluid is leaking into the surrounding areas, we often call that a peritonsillar abscess. So this is the distinction we make on cross-sectional imaging between the linear septations with lymphoid hyperplasia, the intratonsillar abscess if it's confined to the palatine tonsil, and the peritonsillar abscess if the fluid leaks into the surrounding soft tissues. But we remember that the surgeons and the pathologists may call both of these a peritonsillar abscess, and that abscess is not actually within the adenoidal tissue. So that's the pharyngeal mucosal surface or space, and a majority of what we see around here is cancer, and we'll talk about that in the future lectures. So next we have the masticator space. So we have this space here in purple out laterally. So here we have the muscles of mastication, we have the posterior aspect of the mandible itself, and importantly we have cranial nerve V3 that's going up towards ovale within the masticator space. And we remember the zygomatic arch separates a suprazygomatic masticator space from an infrazygomatic masticator space, sometimes called the infratemporal fossa by the surgeons and the temporal fossa above the zygomatic arch. But pathology may be directed under the zygomatic arch either superiorly or inferiorly because of those fascial layers we talked about before. So that is the masticator space where we think about the muscles of mastication. So here's that same axial T1 image, and here I've outlined for you the masticator space. And we see where that is in relationship to that parapharyngeal fat more medially. So we have the masseter, the medial pterygoid, the lateral pterygoid, all within that masticator space. And we remember, again, importantly, the cranial nerve 5 and V3 division that is going down through ovale to get to that masticator space. So we'll talk about that more later in our lecture about cranial nerves, but it's very important when we have a tumor in the masticator space to evaluate, in this case, the extension of cranial nerve V3 up through ovale. So here we see normal non-enhancing cranial nerve V3 in ovale on the right, but on the left we see this perineal tumor spread going up and enlarging the semilunar ganglion, consistent with perineal tumor spread going through ovale of that area. So anytime we have a tumor in the masticator space, we remember to evaluate V3 as it extends up. So a generic lesion of the masticator space is going to push that parapharyngeal fat we see here medially and posteriorly. So when I see that fat pushed medially and posteriorly, it helps me guess the lesion is arising from the masticator space, and I can think about what pathology normally happens to that anatomy. Now, frequently we have odontogenic disease, so we can have a abscess that's from a dental origin, from a tooth, that may be directed back posteriorly because of these fascial layers into that masticator space. So here in this graphic, we see a fluid collection with surrounding enhancement adjacent to the mandible, consistent with an odontogenic abscess. So if I have a case similar to that graphic, where I have a fluid collection with surrounding enhancement in those muscles of mastication, I want to look closely at the dental teeth to see if there's a dental origin abscess. But again, I find that parapharyngeal fat, and I see that the fat here is pushed medially and posteriorly, helping me guess that this lesion is arising from the masticator space at that location. And when I look at the teeth on the bone algorithm, I see that this patient recently had a tooth pulled with a lot of heterotopic bone formation around that empty tooth. And this is the dental origin abscess that arose from this tooth being resected. Now, I also want to remember that sarcomas love the masticator space. We think generically about sarcomas as often tumors arising from the muscles, and because we have those large muscles of mastication, we know that all flavors of sarcomas may happen around this area. Rhabdomyosarcomas, osteosarcomas, chondrosarcomas, just as we see here in this area. Again, I find a lesion in the suprahyoid neck. I find that fat. I see how it's pushed medially, helping me guess that this lesion is arising from the masticator space. And this is a good appearance for a sarcoma at that location. We also want to remember that that masticator space goes up towards the TMJ. So we may have a TMJ pathology like a chondrosarcoma that may have a chondroid matrix that may arise from the TMJ itself. If we do see that chondroid calcification, it helps make that diagnosis more easily in this case. So that is the masticator space. Immediately behind that, we have the parotid space. So we've got the parotid gland here. We have the branches of the facial nerve. We have a bunch of lymph nodes. We remember that the parotid is the first nodal order drainage station of the periauricular skin and the pin of the ear. And we have the vein behind the mandible called the retromandibular vein. So this is the parotid space that is immediately posterior to the mandible and those muscles of mastication. We think about it as having a superficial and a deep lobe that's separated by the facial nerve branches itself. If we can't see the facial nerve within the parotid, we find the retromandibular vein, this vein that's behind the mandible, and we know that the facial nerve goes just lateral to the retromandibular vein, so that helps us divide the parotid into a superficial and a deep lobe. So here's that same axial T1 image, pre-contrasted, and here I've outlined for you the parotid gland in that space. So this is the parotid space that's behind the masticator space at that location. Now, at the skull base, we want to remember that that parotid space has the mastoid tip as well as the styloid process, and in between them is the stylomastoid foramen where the facial nerve is coming out. Again, very important with perineal tumor spread. We're usually talking about cranial nerves 5 and 7 in those cases. So if I have a generic lesion of the parotid space, I find that parapharyngeal fat and I see how it's pushed anteriorly and medially, helping me guess that lesion is arising from the parotid space at that location. So here's a generic lesion of the parotid space pushing that fat medially. So what pathology do we see in the parotid space? So this is a salivary gland, so it can get infected or inflamed. So we may have infection coming from the oral cavity extending back towards the parotid space itself. And remember that the parotid duct goes over the masseter muscle, so we may have accessory parotid tissue over the masseter, and the duct pierces the fascia over the second molar, so we may have infection extending back from the parotid duct to the parotid itself. So early in infection, we may see enlargement of the gland, and late we may see shrinking down of the gland itself if we have a parotitis at that infection of the parotid gland. Now, if we see cystic changes within the parotid itself, we want to try to get as much clinical information as we can to help differentiate that. If I have an older woman with dry eyes and mouth, I think about the autoimmune exochronopathy or Sjogren's syndrome when I see cystic areas within the parotid glands itself, maybe associated with rheumatoid arthritis, but this is usually an older woman with dry eyes and mouth. And early in these cases, we might see replacement of the entire parotid gland with millimeter cysts, as we see on this axial T2 weighted image, where both of the parotid glands are completely replaced by small cysts at that area. So that's what we might see early on both CT and MRI. We might see cysts as well as small lymphoid aggregates within the parotid. Later, we might see larger solid and cystic areas within the parotid itself, as we see here on this axial post-contrasted CT, where we see these cystic areas as well as solid nodular areas. If I know that this is an older woman with dry eyes and mouth, I'm going to think about Sjogren's syndrome or an autoimmune exochronopathy. Now, if I see cystic lesions within the parotid glands, but I know the patient is HIV positive, I'm going to think about lymphoepithelial cysts. Depending on your patient population and the antiretroviral drugs that we give, we may see this less commonly now than we did a couple of decades ago. But here in this graphic, we see replacement of both parotids with several cysts and prominence of the nasopharyngeal adenoidal tissue. So we look for the correlating findings of not only cystic areas within the parotids, but prominence of Waldeyer's ring, the ring of adenoidal tissue around the upper digestive tract. So here's an axial T2 weighted MR, and we see cystic areas bilaterally within the parotid glands. If I know this patient is HIV positive, that's a great appearance for lymphoepithelial cysts in the parotid. And I'm going to look for the associated prominence of adenoidal tissue. Here's an HIV positive patient who had very prominent nasopharyngeal adenoidal tissue, and they had very prominent reactive lymph nodes seen on both sides. Here we see this axial post-contrasted CT with very large reactive nodes bilaterally, the JD nodes or the sentinel nodes bilaterally. Now we also have benign tumors that may show up within the parotid gland itself, both benign and malignant lesions at this area. When we think about the parotid gland, most commonly we think about 80% of those lesions being benign and 80% of those being benign mixed tumors or pleomorphic adenomas. So this is far and away the most common actual tumor of the parotid space itself. It may be superficial or deep, as we see here in this graphic. So it may go both superficial or deep to the facial nerve itself, as we see here in this graphic with this benign mixed tumor or pleomorphic adenoma extending into both the deep and superficial lobes of the parotid. When these are small, usually we have a well-defined lesion with homogeneous enhancement, as we see here on this axial T1 post-contrasted image with fat saturation. It might look like a lymph node or another lesion. So that's why we look at our other sequences, and we know that on the T2, these lesions are often very bright. So we like these to be as bright as a light bulb, as bright as CSF. And if we see a large lesion that's crossing this stylomandibular notch or stylomandibular tunnel between the styloid process and the mandible, that's the stylomandibular notch or stylomandibular tunnel, a very large mass, it's almost always a benign mixed tumor. You see the surrounding soft tissues are not very angry about this lesion in this case, but also the lesion itself is very bright. It's almost as bright as CSF in this case, like a light bulb in the deep spaces. So when we see that, it's almost always a benign mixed tumor or pleomorphic adenoma in those cases. Now, we can have other lesions here. Another benign tumor is the papillary cystadenolymphomatosis or Warthin's tumor. If we have an older smoker, usually male patient, and we see bilateral lesions, as we see here in this graphic within the parotids bilaterally, and solid and cystic areas, we think about adenolymphoma or papillary cystadenolymphomatosis or Warthin's tumor. In my world here in North America, we have our VA hospitals, and if we see parotid lesions in an older smoker at the VA, it's usually a Warthin's tumor in that patient. This is thought of as the second most common benign parotid tumor, and they often show up in the parotid tail, so they may show up as an angle of the mandible lesion in the parotid tail. And about 20% of the time, we remember these can be multicentric, unilateral or bilateral, synchronous or metachronous, so we may see lesions bilaterally within the parotid itself. And they may sometimes have a more aggressive or malignant appearance. Here's an axial post-contrasted CT, and we see lesions bilaterally in the parotid with both solid and cystic areas. If this is an older smoker patient at the VA, I'm going to be thinking about a Warthin's tumor or adenolymphoma in that case. Here's a coronal MRI of post-contrasted T1, and we see here a lesion in the parotid tail. So this is kind of an earring lesion. I see a little bit of parotid tissue that's going around this lesion with both solid and cystic areas. So it may have a much more aggressive appearance and look like a much more aggressive lesion on MRI when it shows up as a parotid tail lesion. Now, we do have some minor salivary gland tumors that may happen within the parotid. Usually we're talking about mucoepidermoid and adenoid cystic as the two most common pathologies for minor salivary gland tumors. But we do have mixed tumors. We can get lymphoma within the parotid, and we can get other pathologies like adenocarcinoma or oncocytoma that may show up within the parotid itself. In my patient population, mucoepidermoid carcinoma seems to be the most common lesion. Some people report adenoid cystic as the most common, but we think about this arising from the glandular ductal epithelium, and here we see a much more aggressive lesion than the benign mixed tumor that almost looks like it has small tendrils extending out from the lesion itself. And mucoepidermoid starts with M, likes to have malignant lymph nodes. So if I think a patient has a aggressive looking lesion within the parotid, I remember the mucoepidermoid carcinoma, and I'm going to look very closely for malignant lymph nodes that may tell me this could be a mucoepidermoid. Now, adenocarcinoma, adenoid cystic carcinoma, we think about as the second most common parotid carcinoma, and it really likes to have perineural tumor spread. So here in this graphic, we see an adenoid cystic carcinoma arising from the parotid, and we can have perineural tumor spread extending out over the masseter. It can extend back proximally along the facial nerve towards the stylomastoid foramen, or there's a connection between 5 and 7, the auriculotemporal nerve, where the perineural tumor spread may extend to the deep spaces of the cervical soft tissues towards ovale at that location. So here's an axial post-contrasted MR with fat saturation. We see an enhancing lesion within the parotid, and this lesion is extending deeply towards ovale, and it looks like it's getting on V3 and then going over to invade the mandible. So if I have an aggressive-looking tumor within the parotid, and I see what I think is perineural tumor spread, I'm going to remember adenoid cystic carcinoma as a possible spread tumor with perineural tumor spread, either over towards ovale or towards the stylomastoid foramen, where 7 should be coming out. I also want to remember the parotid is the first nodal order drainage station of the pinna of the ear and periauricular skin, so we can get lymph nodes within the parotid gland itself. So if I know this patient had a squamous cell carcinoma or melanoma resected from the pinna of his ear a few months or a year beforehand, and the patient shows up with a mass within the parotid, such as this case, I want to remember that we can get lymph nodes within the parotid. That's very different than the other salivary nodes that do, other salivary glands that do not have lymph nodes. The parotid encapsulates late. It wraps around the retromandibular vein. That's why the parotid has lymph nodes and the other salivary glands do not. So that is the parotid space and some of its more common pathology. Next, we have the carotid space. So the carotid sheath or space is a long tube that's extending up in both the suprahyoid and the infrahyoid neck. It's contributed by all 3 layers of the deep cervical fascia. So we have the carotid, we've got the jug, and we have parts of cranial nerves 9 through 12 that may all happen within the carotid sheath or space. So here's that same axial T1 image, pre-contrasted, and here I've outlined for you the carotid sheath or space. And we remember again that this is a tube that extends up and down in both the suprahyoid and the infrahyoid neck. So in our world here in North America, in the East Coast, it's often called the pre-styloid or post-styloid parapharyngeal space. So what is sometimes called the pre-styloid parapharyngeal space is what I refer to as the parapharyngeal fat, and the post-styloid or retrostyloid parapharyngeal space is what I refer to as the carotid sheath or space. And this is a long tube that extends up from the skull base down towards the thoracic inlet. So pathology may be directed superiorly or inferiorly because of these fascial layers. And we remember that there is some variability. So sometimes we see kissing carotids like we see here on this collapsed view of a cervical MRA. So it's not a really strict tube. We may have pathology that extends medially or laterally to kind of escape through holes in those fascial layers. So here's a generic pathology of the carotid sheath or space, and I see how that parapharyngeal fat is displaced anteriorly and a little bit medially, helping me guess if this lesion is arising from the carotid sheath or space. So after I make a space-specific diagnosis, I can start thinking about the imaging findings and make a space-specific differential. So any pathology that happens to the carotid or the jug may happen at this location. If we have a pseudoaneurysm, here we have a nice dissection flap on the CTA examination, and here we see a post-traumatic or post-dissection pseudoaneurysm with swirling blood on the angiogram and a dissection flap where we may have a carotid sheath pathology from the carotid. Now, if we have a tear in the intimal lining of the carotid wall, like in this graphic, we may have delamination of blood products. So a carotid dissection may delaminate and cause a pseudolumen with a true lumen with that dissection flap itself. And this may be bright on a pre-contrasted T1. So if we think someone has a dissection of the carotid or the jugular, or the carotid or the vertebral arteries, we may do an axial T1 with fat saturation, and we see this very bright signal intensity adjacent to the true lumen of the carotid. That's a great appearance for a carotid dissection with that delaminating blood dissecting along that surface. Now, if we do have jugular vein thrombosis or thrombophlebitis, like we see in this collapsed view MRV, we see all these collaterals going around the thrombosed internal jugular vein. We may have thrombophlebitis if we have infection, or just thrombosis if we have a filling defect within the jugular vein itself that causes occlusion at that area. Now, we do have tumors in the carotid sheath or space, and here we often talk about carotid body tumors and glomus vagalis. These are just tumors that are rising from these different ganglia, and we give them different names based on which ganglia they arise from. So if it arises from the glomus body at the carotid bifurcation, we call that a carotid body tumor. If it's centered 2 centimeters below the skull base, we call that a glomus vagali. If it's centered at the jugular foramen, we call that a jugular paraganglioma. And if it's centered on the cochlear promontory, we call that a glomus tympanicum. All of those are paraganglioma tumors. We just give them different names based on which of these glomus bodies they arise from. So if we have a lesion separating the ICA and the ECA at the bifurcation, that's a good appearance for a carotid body tumor or a carotid body paraganglioma. And we think about these as the salt and pepper lesions. It's a lot of bit of pepper, a little bit of salt. So here in this axial T1 before contrast, we see all the flow voids within this lesion. So it's pushing the parapharyngeal fat anteriorly, so it makes me think this is in the carotid sheath or space, and I see all those flow voids within it. That's the pepper of the salt and pepper paraganglioma. So that's a great appearance for a carotid body tumor if it's splaying the ECA and ICA in between those two lesions. So here's a nice angio case where we see a very nice blush of this carotid body tumor between the ECA and ICA vessels, nicely splaying them. So we see a nice intense tumor blush. So if we have a glomus vagali, if we have a tumor that's centered 2 centimeters below the skull base, we see here in this graphic displaying between the internal carotid artery and the internal jugular vein by this tumor, and we see all these flow voids that give the pepper appearance with these salt and pepper paragangliomas. So here is an axial T1 post-contrasted image. Here's the carotid and here's the jug. It's in between those two structures. So that's a great appearance for a carotid sheath or space tumor, and it's avidly enhancing. When I do the coronal, I look very closely to see that this lesion is centered 2 centimeters below the skull base, so that's a great appearance for a glomus vagali. So again, if it's centered at the bifurcation, that's a good appearance for a carotid body tumor. If it's centered 2 centimeters below the skull base, that's a glomus vagali. And if it's centered at the jugular foramen, that's a jugular paraganglioma. We can also get schwannomas, benign nerve sheath tumors that may happen in the carotid sheath or space. So here we look for a fusiform carotid sheath or space mass. We don't see the flow voids that we see with paragangliomas, but when they get large enough, they have intratumoral cysts. And if we see several schwannomas, we may consider NF2 or neurofibromatosis type 2 with multiple inherited schwannomas, meningiomas, and ependymomas. So here in this graphic, we see the carotid and the jug, and this lesion between them splaying them. Here's a correlating case, an axial T1 post-contrasted. We see a large intratumoral cyst within this lesion. The lesion is in between the internal carotid and the jug, so that tells me it's within the carotid sheath. I see the parapharyngeal fat is displaced anteriorly, so that's a good appearance for a schwannoma. I sometimes am able to differentiate a schwannoma from a neurofibroma because the neurofibromas are very low density, as we see here in the infrahyoid neck, between the carotid and the jug. So it's between the carotid and the jug, so it's a good appearance for a carotid sheath or space lesion, but here it's very low density. So neurofibromas are often very low density. So those are the lesions within the lateral suprahyoid neck. We'll finish up here in the last couple of minutes with the posterior spaces. Here we have the retropharyngeal space and the danger space. So around the vertebral bodies, we have the perivertebral space, that fascia layer that goes down and touches the transverse process. It's around the paraspinal musculature. And then we have the retropharyngeal space that is between the upper digestive tract pharynx and the vertebral space itself. So first we have the retropharyngeal space. So here we have fat and lymph nodes in that retropharyngeal space that's between the vertebral bodies and the pharynx itself. So here's that same axial T1 image And here I've outlined for you that parapharyngeal space that's in between the pharynx and the vertebral bodies. So we not only have fat here, but we also have lymph nodes that are very important drainage of the upper digestive tract. And we think about that space as kind of a trap door somewhere around T3, where pathology from the prevertebral space may extend down into the danger space to get to the mediastinum. So it's a very important conduit for infection from the retropharyngeal space. Here's a generic pathology of the retropharyngeal space. We see it's in front of the longus coli or capitis muscles. And here's an example of a case with benign fluid at this collection. We want to be very careful that we're not actually scanning too quickly to see an abscess. So with our very fast scanners, and we do CTA studies, here we have fluid at this location. I may think about doing a second pass through this area if I think this may actually be an abscess of fluid collection with surrounding enhancement. So I see how that pushes back the longus coli or capitis musculature, telling me that this is in the retropharyngeal space at that location. And we might see non-abscess fluid, such as what is seen with longus coli tendinitis or hydroxyapatite deposition. If we see focal calcification within the longus coli and capitis musculature, or if we have internal jugular vein thrombosis, that may cause fluid to leak into the retropharyngeal space at that location. So if we do see fluid here, we're going to look very closely at the jugular veins, and we're going to look for longus coli tendinitis or hydroxyapatite deposition with high density within the longus coli and capitis musculature. Now we remember that we may get lymph nodes at this location. So they're often snuggled up in between the longus coli capitis muscles and the carotid and the jug out laterally. That's where we see retropharyngeal nodes. And we may see these not only with nasopharyngeal carcinomas, but also with oropharyngeal or hypopharyngeal cancer. So posteriorly, the last space we'll talk about is the perivertebral space. So this is going to be in both the suprahyoid and infrahyoid necks, wrapping around the vertebral bodies and behind that retropharyngeal fat and lymph nodes posteriorly. And it goes down and touches the transverse processes. So we sometimes talk about a prevertebral portion and a paraspinal portion posteriorly. So here's that same axial T1. And here I've outlined for you the perivertebral space around those vertebral bodies. And we know that those vertebral bodies are great niduses for things like tumor and infection. So if we have pathology from the perivertebral space, we find those longus coli and capitis muscles, and we see here how they're displaced anteriorly, helping me guess that this is arising from the perivertebral space, not the retropharyngeal space, which should be in front of those longus coli and capitis muscles. And we remember again that those vertebral bodies are great niduses for tumor and infection. So if we have infection around that area, the infection may be forced into the epidural space because of those fascial layers as that perivertebral fascia goes down and touches the transverse process, like in this case where we have infection-specific material that's forced into the epidural space. And we can also get tumor, as we see in this space, where the tumor is forced down into that area and destroying the bone. And we see again those longus coli capitis muscles are displaced anteriorly, helping me guess that this pathology is arising in the perivertebral space. So we can think about the suprahyoid neck and the infrahyoid neck as having all of these spaces, and we think about how the lesion is interacting with the parapharyngeal fat. So I want to find that parapharyngeal fat. So this is an example of where sometimes the axial T1 pre-contrasted might be more important than the post-contrasted imaging in the extracranial head and neck. Because if I pay attention to where there is air and where there is fat, I can sometimes tell you exactly what the pathology is. So I find that parapharyngeal fat, and I know that pathology from the pharyngeal mucosal surface or space will push that fat posteriorly and medially. Lesions from the masticator space will push it medially and posteriorly. Lesions from the parotid space will push it medially and anteriorly, and pathology from the carotid sheath or space will push that fat anteriorly. So I can guess what space the pathology is arising from to make a space-specific diagnosis. So I want to remember those spaces and think about its effect on either the longus capitis or the parapharyngeal fat. So if I find that longus capitis and coli complex muscles I know that retropharyngeal fluid or retropharyngeal space pathology will push that fat or push those muscles back posteriorly or flatten them. But pathology arising from the vertebral bodies, like the perivertebral space musculature, will push that fat more anteriorly. So that's what I want to think about with spaces in the superhyoid neck when I'm thinking about this pathology. So I want to think about where the mass is centered, how does it interact with either the parapharyngeal fat or the longus coli and capitis complex. I want to assign that lesion to a space of origin and then match those radiologic features to a space-specific differential. So we have all those cervical fascia layers that define our deep spaces. The parapharyngeal space displacement is very important. I remember the pharyngeal mucosal surface is really where squames live. The masticator space, we can get dental origin infection and abscess, but it's where sarcomas live. For the parotid, we have the facial nerve. Remember that in the carotid sheath or space, we have the carotid and the jug, as well as parts of cranial nerves 9 through 12. In the retropharyngeal space, we have fat, but we also have lymph nodes. And in the perivertebral space, we remember that those vertebral bodies serve as great niduses for tumor and infection. So some of those spaces may be displaced down, and they exist in both the infrahyoid neck, where we have the thyroid, the larynx, and the parathyroid glands. We'll talk about those more in the upcoming lectures. But that is briefly a quick glimpse of the global anatomy of the superhyoid and infrahyoid neck. So as I mentioned at the beginning, Dr. Van Rensburg has helped me put together kind of this lecture series, and we'll be going through in the next couple of months all these complicated areas in the extracranial head and neck, focusing a lot on the skull base and the temporal bone and cranial nerves. But that's a brief glimpse into global head and neck anatomy and looking at the superhyoid and infrahyoid neck. And I thank you very much for your attention. Okay, so are there any questions about anything?
Hello, Rick, can you hear me?
Yep, I can hear you.
Hello. Well, at the onset, just thank you very much. I mean, it's just so obvious what a great teacher you are to simplify complex concepts, anatomy and pathology into something that every person who attended tonight can apply in their practice tomorrow and increase their level of confidence in reporting. Secondly, I think I just have to make the concept, the comment that fat is our friend in the skull base and in the deep faces. And for our audience, never forget it. Fat is your friend. So the reason why I mention it is that T1 sequences, and I think it's important just in terms of a protocol, that you do need a T1SE spin echo of the skull base. In my opinion, as compared to a fast spin echo or something, to get the real fat signal. It can work in most instances, but sometimes you might caught out. So personally, I still believe in straightforward T1SE. I don't know what your thoughts on that is.
Yeah, I really prefer having a basic axial T1 pre-contrasted and the simple T2. We're getting away with that sometimes with all of these very different fancy sequences, but the basic T1 and T2 give you a lot of information. And even doing SPGR or FSPGR, MP RAGE, that's not really a T1. And we want to be very careful about marrow invasion, especially the skull base, when we think about that.
Yeah, so the point I want to make is going forward in this lecture series is that you have, we plural, whoever does head and neck or base of skull imaging has to be very careful with your sequences as not to annihilate or suppress your best friend fat, because
Right.
it's very, very easy to detect pathology by suppressing fat, but it might not give you the information. So that's just one point is that I think in the head and neck and base of skull that we need plain sequences that show us where the fat is. But then we have a few seconds, we have 3 minutes to our participants. You can post your questions in the inbox, emails, compliments or complaints. Complaints to me, compliments to Dr. Wiggins, that he can answer live. But again, while I have the airtime, I just want to thank Rick for being available to do this lecture series for free for the RSSA over a period of a year. That's a huge commitment. And just in advance, Rick, thank you very much. We really appreciate it, and I think you'll get a lot of kisses in your inbox on your website or on your Facebook page. But anyway, are there any questions in the inbox, Johan?
Yep, I'm going through some of them.
Yeah, Dr.
Elric asked about the SMAS. Yes, sir.
The easiest is probably just read out the question and then answer the question. You don't have to type out every answer. That will take a long time. I think just read the question and then obviously give your answer. That will be quicker.
So one of the questions was about the SMAS. And I think what you're talking about there is the superficial muscular aponeurosis space. To the plastic surgeons, they talk about the superficial muscular aponeurosis system. So to the plastic surgeons, they're really talking about the voluntary and involuntary muscles of facial expression. For us on imaging, we talk about the SMAS, the superficial muscular aponeurosis space. So not only the muscles of voluntary and involuntary facial expression, but also the fat around them. So sometimes, especially if you have a lot of cosmesis in your practice, people inject a lot of different materials into the subcutaneous tissues, and different types of plastic surgery as well as flaps may make the SMAS, the superficial muscular aponeurosis system, very difficult to evaluate. So I do try to go into detail about that area, but we want to remember that kind of incidental things like cystic acne, tricholimal cysts, sebaceous cysts can happen in that area. So we may just get incidental things like cysts there that are not really very exciting. Okay. Another question about sorry, did you have a comment on that, Leon?
Yes, a comment on SMAS. I think in my personal experience, from a radiological point of view, SMAS is most probably in the head and neck and the deep spaces, most important in depicting perineural tumor spread. It's just as diffuse enhancement along the fascial spaces. I've had very few referrals in my life for cosmetic imaging, but I think the important thing is and we can get back to that, and perineural tumor spread is that the SMAS, the muscular fascia is a very important avenue of perineural tumor spread.
Yeah, so when we think about all the foramen around the skull base, we want to see a nice fat pad under them, but also the foramen around the face, especially the supraorbital foramen and infraorbital above and below the orbit, where we have V1 and V2. We'll talk about that more later. But we want to see a nice fat pad in front of those foramen. So when we have a skin squame, different than an upper digestive squame, we look more for perineal tumor spread because that's very hard to palpate. And it's really our job as head and neck imagers. It's really outside of the head and neck. It's not really something that's discussed, except maybe for prostate. It's really the head and neck imager's shtick to talk about and evaluate perineal tumor spread. And if we don't think about it, we're not going to see it. So we have to remember to evaluate those nerves all the way along their course. And we'll talk about that more in future lectures.
Okay. Are there any more questions? Just go through them, Rick, please.
Yeah, there's more questions about the SMAS, the superficial muscular aponeurosis space or system. I don't think there's an accepted radiology anatomy. We just think about all the voluntary and involuntary muscles of facial expression. We don't often talk in our reports about orbicularis oculis or orbicularis oris or the levator nasii, these muscles in particular. We just remember that they exist there in the SMAS, and when we do have skin squame or melanoma or basal cell, we'll look at some of those cases later in this lecture series. We do remember to look, as we mentioned, for peritoneal tumor spread. That's very important when we evaluate those cases. So I don't think there's a direct system. There have been a couple articles about imaging of the SMAS. So we may have venolymphatic malformations. There's the word hemangioma is kind of a grab bag term that's applied to a lot of different pathologies. But we do have niche and rich, the rapidly involuting cavernous hemangiomas, and the niche, the non-involuting, as well as facial hemangiomas that may happen in that space. There was another question about paragangliomas and osseous changes. We'll talk about that more when we talk about the lower cranial nerves. But when we look at the jugular foramen, if we look at the osseous changes, so if we have a well-done bone algorithm CT, we can sometimes tell you exactly what the pathology is. So when we see the permeative destructive changes, that's really good for a paraganglioma. The increased density we see with the meningioma or the smooth scallop changes that we see with the schwannoma sometimes help us make the differential. That's very important. Usually with a paraganglioma, we think about the lesion itself having salt and pepper changes. It's usually a lot of pepper and a little bit of salt. But for all of the pathologies of the head and neck, it's very important that we think about how the surrounding anatomy is reacting to that lesion. And it's not something we're usually taught about or we think about it. But if the surrounding tissues are very angry, it's very different for an aggressive malignant lesion than if the surrounding soft tissues are very benign and do not appear angry, like a benign or a benign mixed tumor. So the osseous changes with the paraganglioma are permeative destructive. So we see a decreased density of the bone, and it looks like it's rat chewed. It's destroyed. So this is an aggressive destroying bone around that area. So that's what we see with paraganglioma. With a metastatic focus, we're going to look for a more solid lesion that is also destroying bone, but it's a marrow replacing process. So when we talk about the central skull base, we'll talk about those, and it's really a wide differential. Mets, myeloma, lymphoma, leukemia, plasmacytoma, EG, sarcoid, a lot of different things can present as a marrow replacing process. So we try to get some clinical information to help us differentiate those pathologies.
Okay, any more questions? We're over 9 o'clock, and your time is very precious. Any more pressing questions in the inbox, Rick?
No, I think that's all I got. Thank you guys very much. Until I can get over there in real life, we will try to put on this lecture series for this year, and hopefully you'll enjoy the talks themselves. Thank you very much.
Thank you very much, Rick. Thank you again for your contribution and free time to the RSSA. Our next lecture in the second part of the series will also be on the 12th of March. Yeah, we look forward to it, and more importantly, over time, we look forward to welcome you to South Africa at some time. And the lecture will be available on the RSA website most probably within 48 hours. Thank you very much, and good night, everybody. Thank you, Rick, and have a good day. You still have a day's work ahead of you.
I do, but good night to all of you over there. Have a good night. Thank you so much.
Good night.